Good afternoon and welcome to our webinar, Healthcare Design and COVID-19, How We Respond and Recover in Today's Market. Thank you all for joining us, and please continue sharing your ideas for programs at communications@architects.org. We'll share this contact information again at the end of the program. I'm Eric White, Executive Director of the BSA. And before we begin, I want to share a quick update on some of the things that we're working on to support you during this challenging time. You can continue to find information, including local and national resources, at our website, architects.org. I want to call attention to the firm's Best Practices Guide to COVID-19 that's been developed by a task force led by BSA President Candice Barter AIA. You can also find information on our work helping identify potential facilities and locations for the state to set up in response to COVID-19, including emergency healthcare as well as isolation areas. And I also want to note that you can find AIA's new Architect's Guide to Business Continuity. For now, we are planning 2 webinars a week. And this is also a good time to remind you that our knowledge communities are back. They're holding their monthly meetings on virtual platforms. And we hope you'll join these meetings from the safety of your homes. To stay up to date, we welcome you to join BSA Connect, a LinkedIn forum. It's a place where you can pose questions, share and find community, and you can also find it by searching BSA Connect on LinkedIn. There are a number of advocacy efforts underway as we continue to work with our partners in the building industry. Some of these at the moment, our latest efforts are focused on developing recommendations to the state and communities for virtual methods to continue the public process and permitting. Now let's start the session on healthcare design and COVID-19. And before we begin, a few rules. Because we have a large number of participants, you will all be on mute. For our Q&A period, we will have selected a number of questions that were submitted ahead of time. Thank you for sharing all these. However, due to the overwhelming response, we have selected some key questions to address at this time, but we will continue to use your questions for BSA programs coming up. And during the program, feel free to use the chat option on the lower middle right side of your screen to interact with other participants, as well as the Q&A option to ask questions directly to our presenter. If time permits, she will try to answer these. Now, this session is being recorded and will be posted on the COVID-19 resource page, which also has all of our past webinars. And you can find that at architects.org, and this session should be up by early next week at the latest. And now I'm excited to introduce our speaker. Candice Barter AIA is an Associate Vice President and Healthcare Principal at HGA. Her passion for healthcare projects draws from an extensive experience working with clients such as the Boston Children's Hospital, Yale New Haven Health, and Concord Hospital. A student of the industry, Candice dedicates time engaging in healthcare policy discussions, as well as researching and exploring emerging technology and data solutions for healthcare planning. Candice, welcome and thank you for joining us today.
Thank you, Eric. I'm very pleased to be here, and I just wanted to thank our audience for tuning in. I only wish I had the opportunity to be with you all in person and share some of this information, but I appreciate you joining in, as Eric said, from the safety of your home. I wanted to talk a little bit today about HGA, the firm that I work for, and how we are finding ways to respond and how we're looking towards the future of the impact that this current pandemic will undoubtedly have on not just the design of healthcare spaces, but I believe our society as a whole. First, I wanted to talk a little bit about HGA. We are relatively new to the New England market in terms of having an office here. We have been in this location. We have a Boston office that's been around for about 25 years under the name of Wilson Architects, and HGA acquired them about not quite 2 years ago. And nearly a year ago, we opened a healthcare practice here. We have offices across the nation. We have about 10 locations headquartered in the Midwest, with a number of offices on each coast. As a healthcare design practice, we contribute about half of the billings annually of our firm. Our firm as a whole is around 900 employees, and we have over 300 healthcare professional staff. We are an integrated interdisciplinary firm. We do not have engineering in our Boston office, so we continue to partner with local consultants for that, but we do have architecture and planning, engineering, interiors, and design insight group that we use nationally. Our design insight group represents a series of design researchers, clinicians, lean process engineers, and other atypical design staff that really help us contribute to solving problems like the one that we're facing today. As I said, our Boston healthcare practice started almost a year ago this month. We were anticipating that we would at least all be in the same room to have a little celebration together and potentially reach out to some of our friends and colleagues and clients. We'll have to hold on that. But this is the leadership of the Boston healthcare team that has been developed over the past year. Next, I wanted to talk a little bit about just what we're going to be speaking about today. I don't have a crystal ball. I don't have answers to many of the questions that everybody is posing these days, but I do know that having spent the last almost a year strategizing about building a healthcare practice here, I've been thinking about things in the strategic mindset for a little while, and we've been trying to understand how to change and what ways we need to stay the same to respond to the needs of our clients during this time. So I broke that down into empathy, curiosity, hard work, and then, as Eric mentioned, Q&A. I think one of the things that I'm grateful for at this time is that I work at a firm that has these as our core values. As a firm, we value empathy. We are fueled by curiosity. It even says it on our coffee mugs in our office. And we embrace the hard work that leads to innovation. And I feel like these particularly have given us a good position to move forward at this time. So first, I wanted to talk about empathy. And we qualify empathy as the understanding and being sensitive to others' perspectives. But we think about this not just in terms of our clients. We think about it also in terms of how we interact with our colleagues. And I think at this time, that is even more important than ever. One of the things that we talk a lot about is, in order to have empathy, we must first listen to develop an understanding. As healthcare designers, it can be very tempting to lead with our expertise and thinking that the solution that we perfected on our last 10 similar projects will apply to this one as well. I know that clients rely on us for our expertise, but I do think it's a mistake to lead with a solution without first taking the time to listen to the unique situation that our clients face. And at this critical juncture, I believe that to be even more true. Listening and responding to the needs of our clients is in our job description. It keeps the projects coming in. It ensures that the work that we're doing has value for the clients that we have. But I think it's just as important to turn those skills for listening and for understanding towards our colleagues. As we struggle to adjust to working from home, it can be a little bit difficult to navigate. I have an image up of some of our healthcare team from our office collaborating with others, with clients, with other design team members. And this is the environment that, especially as architects, we find ourselves immersed in. We've moved toward this because it works well for our process. The understanding of collaborating and getting ideas from many different stakeholders really resonates with us, and it is important to our process. Unfortunately, the image that you see in front of you is a stark reminder of what many of us are facing now. It is a lovely, wonderful space, and I know that you all have spaces just like this carved out in your house, but it is difficult to maintain that collaboration that we need and to meet the needs of our colleagues without some work. So as we struggle to adjust to working from home, balancing caring for family, and some would argue too many Zoom meetings, we have to work harder. We have to work to maintain that connection. It doesn't just come naturally by coming in and sitting down at your desk next to your colleague. Our healthcare team in Boston has daily huddle calls. We check in every day via video conference, not just by phone. And we don't just check in to see what deadlines need to be met or what our client needs from us today. We check in to see how each other is coping. Kids, spouses, dogs, other assorted pets come onto the screen occasionally and just add a wonderful layer to what we already know about each other. And I want to talk a little bit about the empathy and the understanding of listening and thoughtfully adding our expertise to a solution that our clients might need from us at this time. So I would argue that none of us are an expert in designing for a pandemic. I don't think many of us have experienced one before, and certainly not one that has been so engulfing like this one. So really listening to our clients and understanding and adapting the expertise that we already have is really important at this time. The plan in front of you is a schematic design plan that we were presenting to a client for an ED renovation at the beginning of March. At the beginning of March, COVID was not something that was a definite. It was not something that, it was something that certainly they were preparing for, but it wasn't something that anyone knew the extent of what was going to be coming into our country specifically. But one of the nurse managers in this meeting brought up the question, what would we do? How would we change this plan that we're developing to ensure that we were able to lock down our emergency department and make sure that no one, not even staff, could get into the ED without being screened? So this was certainly something that we hadn't considered when we started working on the project in December. It wasn't on the radar. So we put our heads together in that meeting. We talked to them about what they knew about COVID and how it is transmitted. We talked to our engineers in the room about how we could ensure that we were providing the right kind of infrastructure to support this. And then we looked at the architecture and what was already there and basically put down a line of demarcation to understand how we would lock down the various entrances that you have coming into an emergency department and really make sure that folks in the main ED were not being exposed to unnecessarily to folks with COVID. So next, I want to talk a little bit about curiosity. I think one of the things I value about the firm that I work for is that they really, they place an emphasis on this curiosity. I love learning more about new things and understanding how to adapt those things and exploring new ideas, especially those that require us to think outside the box. And I think that's a really what's happening and what we're seeing in our situation that we're in today. So looking at our firm and our emphasis on curiosity, this is something that we've done nationally as a way to provide a service for our clients, and also really just to understand how to solve a problem. This was sort of an old school design charrette that was done in a week. It was developed, and the next week figured out how to have the ability to push this out to market. This is called StatMod. It's designed and constructed by HGA and Bolt Construction, and it's a prefabricated rapid response, quick ship airborne isolation rooms and negative pressure wards, and the required support that goes with them. One of the things that we wanted to ensure we had within this design was those critical to quality design features that we always recommend to our clients as best practice. As I mentioned before, we have a very robust design research group, and they spend a lot of time understanding what are the ways that we can improve efficiency and healthcare outcomes for our clients. And we didn't want to lose sight of those as we designed something that could be made readily available to our clients. One of the features of this is that it was tested in a virtual reality simulation by lean process engineers, critical care nurses trained in COVID-19 protocols, and a hospital environmental specialist in infection control. And that virtual reality simulation happened with people in various physical locations all coming together in our virtual reality model to run those simulations and understand in a safe way how to maximize the clinical outcomes for the patients that would be treated here. So some of the things that we've included are increasing staff and patient safety, and ensuring that we're improving clinical outcomes by including things like a donning station in the corridor with hand washing. So you can wash your hands before you put your PPE equipment on, and there's a doffing zone in the room that allows you to remove that and wash your hands before leaving. We do know that hand washing is extremely critical in situations like this. The 15-foot wide room allows space for bed transfers and for the ability to pull in portable X-ray equipment, which is another thing that we know is really important in this environment. There's a head wall with fixed gases and viewing windows and doors from the corridor. Here are a few renderings from the development of this. The one in the lower left, you can see the room for transferring a patient from a stretcher to a bed in a way that's safe and is not requiring the staff to be compromising their PPE or their ability to lift the patient. The one on the lower right showcases two important features of this. One of them is an exterior window. And that window is really important for staff well-being. It also becomes an emergency viewing window for family. One of the things that we know about COVID patients is oftentimes they are spending significant amounts of time and sometimes even end of life time in these locations without any visitors or family able to be accessible based on the protocols to control the spread of this disease. So adding in this window seemed like an important feature that we wanted to make sure we put in here, even as we're trying to design something that is quick and something that we can put out very quickly. The other thing that you'll notice in that lower right photo is there's room in this location for a recliner. We want to make sure, we had some recommendations from the nurse that contributed to this, that patients do need to be in a bed, but even those patients who are not ambulatory it does them a lot of good to sit in a recliner for a period of every day, as it makes them just recover much faster and have a shorter length of stay and improved outcomes. This next slide shows some of the engineering for this. And one of the challenges for the engineering for this is we couldn't use anything that was custom made. Everything had to be readily accessible and quick ship. And we wanted to make it all quick connect so that when this arrives on site, it is very easy to connect this to the existing infrastructure that's there. The HVAC system is HEPA filtered, it's closed looped, and it has 100 CFM exhaust per room. So it truly maintains that negative pressure to protect staff in some of those adjacent work areas. So one of the things that we looked at as the basis for understanding how this was going to be designed is that it really needed to be something that could be pre-manufactured in a fabrication warehouse, but also it had to ship quickly. It had to be something that we wanted it to ship commercially so that it could get very quickly to the locations where it needed to be. So as you can see, this is the largest of the units, and it fits on the back of a truck. On the lower left, there's a photo of the assembly inside one of our warehouses. And we made some modifications so that even the construction factory work was redesigned to allow for that 6-foot distance between workers and to ensure that that was maintained when the construction workers started assembling these on the site. So what happens after these are ordered, the site prep begins while these are getting built in the factory for 2 weeks, and arriving, the site prep is done on your location. So this is just a diagram, a little bit of how these work and how they connect together. What you saw on the previous slide was basically a pod. Those connect together into units. So basically you would connect 4 of these together. That makes a unit, and you can connect 2 units with these support spaces to make a tier, and then add onto those as many tiers as are necessary. The support spaces that are included are patient intake and clean and soil docks, which happen at the north end of the plan, and the staff entry and staff support happens at the southern end of the plan. Additionally, there are IT and communication rooms and electrical rooms that are both accessed from the exterior. And there are meds, nourishment, clean supply, equipment room, and nurses station. And these are all in the center of the plan, which allows you to keep them away from the patient care spaces to avoid contamination. So there's a few uses for this. We thought about how we were going to understand how this got installed. And one of the things that you could use this for is really just to set it up inside one of those alternative spaces that we're using to design. These would allow you to have some isolation units in here. Another way that this can be used is to connect it to a central utility plant for an existing hospital. Or it can be used standalone, and this can be done on a site that's either next to a hospital or in another location. And the tiers can just be ganged together to allow you to provide more as required. So one of the things that we're doing locally is finding other ways to be involved and to utilize the expertise that we do have to help find other solutions. HCIO is a Boston-based healthcare associated infections organization, and this is is an organization that has been around for a little while, studying associated infections and understanding how to mitigate the transmissions of those in healthcare spaces. And they were pretty quick to respond and assemble a healthcare surge solutions task force. Ended up with over 50 organizations, probably represented by many of you on this call, and providing guidance on designing post-acute care spaces in non-healthcare settings. One of the first things that the task force did was to assemble a large number of AEC industry folks and ask us to brainstorm and come up with some solutions for problems that we saw based on conversations with our clients. They also have included in this task force a number of healthcare organizations from around New England. And it was interesting because we had the opportunity to listen to what some of the challenges that they were facing as they moved forward with consolidating and preparing for a surge. One of the things that we heard on that call and a solution that we decided to pursue was that a lot of the hospitals have multiple entry points. And similar to what we had talked about with Trinity and the ED renovation, is how do you understand and make sure that you are providing a safe environment inside the hospital by ensuring that the folks coming into the hospital are protected in the appropriate way. Many of these organizations were pulling together and consolidating to a single entrance, and they had to be very thoughtful about how to contain the patient and the staff flow and avoid things like queuing. It's not a situation where you want a lot of people standing in line if they haven't been screened. So we thought it would be interesting to design a modular solution that would help with that, solve that problem. The first thing that we thought about is, as you're entering the site, how do you screen patients and give them an opportunity to queue in a really safe way? So as you would come into a hospital site, if you were patient, you would be checked out by security and have your temperature taken. And then they would give you an idea of where you should park and take your cell phone number so that you could be texted when it was time for you to come up to be screened to come into the building. So you'd be able to wait in your car. The next thing is this modular, and this could be built either out of modular furniture inside an existing lobby, or it could be put into a tent outside. But really the understanding here is, how do you screen patients and how do you screen staff to ensure this safety? So on the one side, we have a patient flow going in where we've already controlled queuing because we have folks coming up singularly. And we wanted to make sure that we were separating the traffic of those that may be well from those that may be sick. So as you come in and get screened and get your temperature checked, you pass through a hand washing station and you go in and you put the appropriate gown, gloves, and mask on. And then you see a nurse's station to get the rest of your checklist items. And they would either allow you to go into the hospital to go to your appropriate location, or they have some triage spaces out here for those that they believe could be COVID positive. On the staff side, something similar is going to happen. Obviously, they need to be checked in with their badges. And a lot of the hospitals that we talk to are screening and taking the temperature of staff as they come in. They are high-risk patients at this point because of the amount of time that they're spending with folks who are infected. So that staff flow would happen on the right, and all the way to the far right is basically the ability for everyone to leave the hospital, leaving their PPE behind so it doesn't go out into the community. So we imagined that these could be set up and used in front of any number of sites. They could be set up in front of existing hospitals or emergency departments, or they could be used in front of some of the locations like dorm buildings or arenas where other healthcare sites were being acquired. The next step with the HCIO organization is they put together these committees and subcommittees to have an extensive group of us look at and comb through the just immense amount of information that's available, that's being pushed out on COVID-19 and how to strategically look at alternative sites. We focused on providing post-acute care and locations where somebody who's coming from either a hospital setting or coming from home and doesn't need to be in an ICU any longer or in a med-surg bed, but they might still need skilled nursing, or they might not be able to go home. They may live with other people in a group facility. They may not have homes to go to, or they might just live with someone who either can't take care of them or is susceptible to the virus. So we divided up into these committees. I was pleased to be a chairperson on the Modular Intense Committee, and we really pulled together a lot of information, layering the expertise that we do have to try and put this together in a series of tools that would be useful for healthcare providers. The thought being that we do have the ability to look at some of this information and understand what's useful, and then also just to really understand how we could ensure that we were giving them the best kind of information with our expertise layered on top. So next, I want to talk a little bit about what comes next. I think what comes next is hard work. I think we have to do a few things as we move forward. The first is to continue to service our clients at the high level that they have come to expect from us. Now more than ever, our healthcare clients in particular need to understand that they're getting the best solutions that we have for them. And I know that that's not easy to do in this environment. Most of us find ourselves working from home. And as we talked about before, that collaborative model doesn't look like folks gathered around a desk anymore. It looks more like the Zoom meeting that you see in front of you. I used to find it really helpful to work from home. 1 or 2 days a month, I would let my team know that I was going to be working from home, especially if I was writing. Home was quieter, home was less chaotic, and my firm gladly supported my ability to work from home with a laptop and a very robust VPN. But working from home, it doesn't feel like a respite anymore. It's definitely not quieter, and it is certainly not less chaotic. And I think that is true for many of you. I have 2 kids in online classrooms right now, and I have another architect who is my husband at the dining room table, and his conference calls always seem to coincide with mine. The laptop and the robust VPN that my office provides for me really make a big difference in keeping me connected to my work and allowing me to continue to serve my clients. I have found in talking with other people that the firms that invested in the technology to support a flexible work environment are being repaid by a smoother transition to this new normal. They not only have a lot of the infrastructure that's required to do this work from home, but they have a workforce that already has some training in it, and it has an ability to adapt faster. So the next phase, I think, is pivoting to meet current needs. And I think a lot of us are doing this. We are performing emergency preparedness checks for our clients. We are finding ways to help them and support them as they figure out how to deal with a surge that's coming, and in the meantime, a patient population that is much lower than they're used to. I think one of the things that's important in doing this is just continuing to communicate and meet those ever-changing needs. Our healthcare workers are stretched to capacity right now, and I don't think that's just true of doctors and nurses. The facilities folks that we work with every day are spending countless hours, days, nights, weekends, implementing those strategies that we talked about and developing new ones for unique solutions. I think one of the other ways that we can be helpful is just to look outside what our immediate needs are and find ways to be helpful for other people. It can be tough right now. Many of us are responding to pressing needs at home and an uncertain economy. We are watching projects go on hold for a variety of reasons, and that can be stressful. I think one of the things that I recommend for myself and my family and for all of you is just to find ways that you can be helpful. I think we can all use a little more time to connect with people that we might not have had the time to connect with before. We can volunteer by offering to print 3D masks or sew new ones. Really just finding ways that we can contribute positively to what is going on right now. So finally, I think we have to look at and be prepared for what comes next. And I think I'm put this image up here because I think whatever we do, however we move forward, I think it has to be done in the spirit of collaboration. I think the work that the HCIO group is doing and the understanding that we don't move forward as individual firms, but that we have to look at this as an opportunity to pool the knowledge and the resources that we have and find a way to navigate what is going to become a new normal. I think our mindset and everything as we know it is going to be different on the other side of this. I think how we get our groceries, how we wash our hands, whether or not we shake hands, all the way to what are the impacts that this has on healthcare policy, and finally on the way we design spaces. I think one of the things that we have to do on the other side of this is a lot of research. I think we have to understand and think and be thoughtful about how we face an issue like this next time without doing it in a way that is frantic and quick, but that we position ourselves to be able to do this in a way where we are considering things like sustainability and how we can do things in a way that are usable the next time something like this happens. The other thing is I think we have hospitals and healthcare providers who have to start thinking about adding positions for someone doing a risk assessment. I know that I have spent a lot of time over the past couple of years convincing folks that they don't need 9 days of something in their clean supply room so that I could make the clean supply room smaller. I don't think making that room bigger is the answer, but I do think we have to come up with a solution for the problem. And then I also think that we have to just really think about what happens with those long-term projects that are being paused right now. How do we help healthcare workers that have been dealing with unbelievably extreme circumstances and those that have been deferring mental health and who are dealing with that from isolation? So I think what we have to do as we look forward is really just come together in a way that's hopeful and think about how we do this better next time. So at this time, I'm going to move into some Q&A. And I am going to pull, I think there are some questions that are already in here. I'd like to just take a few moments to go through some of these. I think we have time for a few of them. So this first question deals with the codes and the guidelines and what changes. What changes are coming now and what changes are coming in the future? I think in response to this first piece, FGI, CMS, Joint Commission, Department of Public Health, I think anything, the requirements that are being shifted, unfortunately, it's happening very quickly and it seems to change almost daily, and it's different state by state. What happens as we move forward and how this changes the guidelines, I do think it's going to have a big impact on the guidelines. But I think what happens with those guidelines probably follows the role that we set as we move forward in this. For those of us who have an expertise in healthcare design, I think we have to start with best practice, determining as we move forward, what should those best practices be, and allow the guidelines to catch up after that, because I do think we have an ability to be nimble in a way that they are not. So pandemics and extreme weather events, and are there building types in cities and towns that should be designed for this dual purpose? So I think this is a really interesting thought. I think that one of the things that we're discovering is that we do have spaces that are able to accommodate a really large number of patients, but we are struggling to adapt those spaces to provide the right kind of care. I do think a lot of those spaces are either institutional, municipal spaces, or they are spaces that are built by developers. I think you have to incentivize some of those people with, whether it's with tax credits or other things, to understand, are there infrastructure pieces that we could ask them to put in, incentivize them to put in to their spaces that would allow us to respond better to this next time. There is a council on openbuilding.org that talks and thinks a lot about this. I do think that the idea of matching space types that maybe would sit vacant, especially during a situation like this, with the potential for people that are being displaced, I think that's a great strategy. I do think that we have to be thoughtful about who pays for it and how it gets done. How are people carrying on with non-COVID related work in the healthcare facility projects? So I can speak a little bit to this just based on the experience that I've had talking with other healthcare principals across my firm and what's going on in our specific office in Boston. I think one of the things that can be difficult right now is our healthcare clients, even the ones that want their projects to move forward, are pretty distracted right now. And we have to find ways to make sure that we're helping them and moving these projects forward, but also not interfering with the important work that we're doing. I do think in other locations in the country, what I've been hearing is that it doesn't seem to be impacting them in quite the same way that we have been impacted here in Boston and in New England. I don't know whether that is something that continues. They just happen to be seeing lower numbers, I think, at this time than we are. How best do we share amongst our architecture and design community the most recent research, ideas, and design strategies? So this is something that I touched on a little bit, and I do feel as if it is pretty important for us to think about this, because I do think the way forward in this is knowledge sharing. I think it's collaborative. I think it's putting our best ideas together and having the mindset of ideas over ego, not having the idea that we want to protect something that we've done as a firm, but we really want to make sure that the best solution is reached by ensuring that those of us that have the ability to put those resources together are collaborating. I know that HCIO, the organization that I spoke of earlier, all of the information that we collaborated and pulled together, they are working to ensure that that information gets pushed outside of New England. I know that the BSA has a resource that they have been pulling together information, as well as the information that's being pulled together from the AIA, American Academy of Health. I just feel as if the focus of this has to be collaboration and understanding. The research community in design research really pushes for the sharing of that research, because the more research that we have access to, the better the outcomes we can get from that research. I think the collaboration is key in this one. What are clients around the country doing to deal with the surge, and how close is it to typical ICU standards? So I think, again, some of the things that I think we're doing here in New England are common amongst what's happening with our counterparts in other parts of the country. I think the understanding of how to enact your emergency preparedness, how to understand how those guidelines are being relaxed or changed, or what are the things that CMS is doing to allow us to move forward. I think understanding what you have and understanding what you need seems to be what's happening. I do think that the ICU standards are being relaxed a bit. I can't speak to that all across the country, but I do think that it's interesting. We've spent a long time moving away from high acuity and large numbers of beds in hospitals and pushing healthcare into our communities. And I think we're finding that we're not prepared for something like this. And partially because we have asked our healthcare systems to operate on very small margins and only provide the beds that they absolutely need. And I think we have to rethink that going forward. So I just wanted to close by saying that, first of all, thank you for listening and allowing me to share with you. I think as designers, we have to find a new way of working. Just as all of the rest of our society is going to have to find a little bit of a new normal as we move forward, I think we have the ability to apply the design thinking that we are so good at to the new problem of how to stay connected to our projects, our clients, to each other. And I think we'll be good at that, but I do think we have to take the effort to do it. We are constantly listening. We're striving to understand. We're learning about how to adapt spaces that were never intended to be used to provide healthcare. We are continuously improving. I think we're trying to find small ways to contribute to the amazing work that our healthcare clients are doing to keep our communities safe. And I think we will continue to do this important work, though I do believe our process and our outcomes will be forever changed by what we're experiencing right now. Eric, did you want to finish up?
Well, Candice, thank you so much. And I think the advice that you've given is important to all of us. We really are living in a new normal and learning and focused on improving. And I think, as you pointed out, the focus is on collaboration at this point and working together to get through this. So thank you. And thank you all for joining us. Please share your feedback at communications@architects.org. You can stay up to date on our latest news at architects.org or through Facebook, LinkedIn, and Twitter, as well as, of course, our e-newsletter, Currents, which now goes out on Mondays and Thursdays. Before I go, I want to take a moment to publicly thank all my colleagues on staff. They are working diligently to keep you up to date on the most current and useful information. And please share with us your thoughts and needs at this time. And finally, please join me in thanking Candice for sharing HGA's work with us today. We know that your life has been turned upside down and truly appreciate your willingness to take the time and share your knowledge. I know it's challenging working with your family and your husband to be able to figure out how to do work and family at the same time. Thank you for what you do and for doing it so well. And a reminder to all of you, be safe, be healthy, and be kind. And thank you. We'll see you next week.